and welcome to my lecture on breech delivery. This is Doc Ina. To download my lecture deck, please go to my WordPress site, Docina Obigayne. References for this lecture include the following: Williams Obstetrics 25th edition, ACOG SMFM Obstetric Care Census on Peri-Viable Birth, ACOG Committee Opinion Summary number 745, and UpToDate.com. And here is the outline of my lecture. So basically, we have three kinds of breech presentation. So we have the frank breech, the complete breech, and the incomplete breech presentation. With frank breech presentation, the lower extremities are flexed at the hips and extended at the knees, such that the feet lie very close to the fetal head. So with a complete breech, both hips are flexed and both knees are also flexed. With an incomplete breech, one or both hips are extended, and as a result, one or both feet or knees lie below the breech, such that a foot or knee is lowermost in the birth canal. A foot-length breech is an incomplete breech with one or both feet below the breech, such as you see here in this picture. Of third breech fetuses, the neck may be extremely hyperextended, and this is what we call the stargazing fetus. This is what's depicted here in this ultrasound picture on the left. Fetal or uterine anomalies may be more prevalent and are sought if not previously identified. Now, with this hyperextension, vaginal delivery can result in injury to the cervical spinal cord. Thus, if identified at term, this is an indication for cesarean delivery. Now, if we have a transverse lie fetus and similar hyperextension of the fetal neck, then we apply the term flying fetus instead. There are risk factors for breech presentation, and this include the following: early gestational age, abnormal amniotic fluid volume, multifetal gestation, hydrocephaly, anencephaly, structural uterine anomalies, placenta previa, pelvic tumors, and a prior breech delivery. Following one breech delivery, the recurrence rate for a second breech presentation is about 10%, whereas a subsequent third breech is about 28%. Now, how do we diagnose a breech presentation? Of course, we start with a very good physical examination, and we start with the Leopold's maneuver. So here are the typical findings for a breech presentation on Leopold's maneuver. So LM1 will be cephalic or head. The LM2, fetal back left or right. LM3, if not engaged, the breech is movable above the pelvic inlet. And LM4, after engagement, the fourth maneuver shows the firm breech to be beneath the symphysis. How about internal exam findings? Now, in some cases, the anus may be mistaken for the mouth, and the ischial tuberosities may be mistaken for the malar eminences. Now, with careful examination, however, the finger encounters muscular resistance with the anus, whereas the hard, less yielding jaws are felt through the mouth. The finger also, upon removal from the anus, may be meconium stained, and the ischial tuberosities in the anal opening form a straight line, whereas the malar eminences and the mouth form a triangular pattern. Now, how do we decide which route of delivery to do for breech presentation? Now, there are many factors to consider before we can decide whether we do a vaginal delivery or a cesarean delivery. And here are the factors to consider. So first will be the fetal characteristics, maternal pelvic dimensions, coexistent pregnancy complications, operator experience, patient preferences, hospital capabilities, and of course, fetal gestational age. Now, for preterm breech fetuses at 32 to 36 weeks, the decision whether to do a cesarean or a vaginal delivery shall depend on fetal weight. And the SOGC recommends that vaginal breech delivery is reasonable when the estimated fetal weight is more than 2,500 grams. For preterm fetuses, that's about 23 to 28 weeks, studies describe no improved survival rate with planned cesarean delivery or with an outright cesarean delivery. Okay, so for peri-viable fetuses, so most societies will define a peri-viable fetus at around 20 to 25 weeks AOG, and a consensus workshop of perinatal organizations concluded that available data do not consistently support routine, or an outright CS to improve perinatal mortality or neurological outcomes for very early preterm infants. Now, a subsequent joint statement by the ACOG, that's the American College of Obstetricians and Gynecologists, and the Society of Maternal Fetal Medicine suggested consideration, no, consideration for a cesarean delivery for peri-viable fetuses beginning at 23 weeks to about 24 weeks. Now, this statement or guideline recommends an outright CS for fetuses who are 25 weeks AOG. And it doesn't recommend cesarean section for fetuses who are 22 weeks and below. How about term breech fetuses? Now, current obstetrical thinking regarding vaginal delivery of the term breech fetus has been influenced largely by the results of the term breech trial, and we also call this trial as the HANA trial. This trial or study showed that a planned cesarean delivery is associated with a lower risk of perinatal mortality compared with a planned vaginal delivery, and that cesarean delivery is associated with a lower risk of serious neonatal morbidity. This is also the reason why most obstetrician gynecologists worldwide would prefer to do a cesarean section for a term breech fetus instead of doing a vaginal delivery. Now, since the trial, additional data favoring CS has come from the WHO, and the WHO reported improved perinatal outcomes for the term breech fetus with planned cesarean compared with a planned vaginal delivery. In contrast, however, there are other studies that support vaginal delivery as a suitable option for term breech fetuses, one of which is the PREMODA study. And this study showed no differences in corrected neonatal mortality rates and neonatal outcomes according to delivery mode. There's another study called Dil Breech Study Group in France, and they showed no excessive morbidity in term breech singletons delivered vaginally provided strict fetal biometric and maternal pelvimetry parameters are applied. Now, the ACOG makes the following recommendation regarding a term breech fetus or the mode of delivery for a term breech fetus. The decision regarding the mode of delivery should consider patient wishes or preferences and, of course, the experience of the healthcare provider or the obstetrician gynecologist. A planned vaginal delivery of a term singleton breech fetus may be reasonable if under hospital-specific protocol guidelines for eligibility and labor management. If a vaginal breech delivery is planned, a detailed informed consent should be documented that includes the risk that perinatal or neonatal mortality or short-term serious neonatal morbidity may be higher for a vaginal delivery than a CS. And obstetrician gynecologists and other obstetric care providers should offer ECV or external cephalic version as an alternative to a planned CS for a woman who has a term singleton breech fetus and desires a planned vaginal delivery. And external cephalic version should be attempted only in settings where a cesarean delivery or services for cesarean delivery are readily available. Now, what are the delivery complications? With vaginal delivery, especially with a lower or a thin lower uterine segment, delivery of the aftercoming head in a breech fetus through an incompletely dilated cervix or application of forceps may cause vaginal wall or cervical lacerations and even uterine rupture, although that's quite rare. Manipulations may also extend an episiotomy, thus creating deep perineal tears and increased infection risks. Anesthesia that's sufficient to induce uterine relaxation during vaginal delivery may also cause uterine atony and therefore postpartum hemorrhage. Now, compared with cephalic presentation, umbilical cord prolapse is more frequent with breech fetuses. And birth trauma can include fractures of the humerus, of the clavicle, and the femur. Rare traumatic injuries may include brachial plexus injury and paralysis, spinal cord injury, vertebral fracture, especially if great force is employed. In many fetuses, especially those that are preterm, the breech is smaller than the aftercoming head, And moreover, unlike cephalic presentations, the head of a breech-presenting fetus does not undergo appreciable molding during labor. Thus, if vaginal delivery is being considered, fetal size, the type of the breech, and the degree of neck flexion or extension should be evaluated. In addition, pelvic dimensions are assessed to avoid head entrapment from cephalopelvic disproportion. So to be able to do this, the feet, the and so to be able to do this, then a sonography and fetal pelvimetry are options. Sonographic fetal evaluation can identify gross fetal anomalies such as hydrocephaly or anencephaly, and this will identify many fetuses who are not suitable for vaginal delivery. Ultrasound will also help to ensure that the cesarean delivery is not performed under emergency conditions for an anomalous fetus with no chance of survival. Head flexion can usually also be determined sonographically, and for vaginal delivery, the fetal head should not be extended. Sonographic identification of a nuchal arm may also warrant cesarean delivery to avoid neonatal harm. Many protocols use fetal weights of more than 2,500 grams and less than 3,800 to 4,000 grams or evidence of growth restriction as exclusion criteria for a planned vaginal delivery. And a biparietal diameter of more than 90 to 100 millimeters is often considered a contraindication for vaginal delivery. So all of these may be determined through ultrasound. Here are the factors that favor cesarean delivery of a breech fetus: lack of operator experience, patient request for a CS, large fetuses, meaning the fetus is more than 3,800 to 4,000 grams, apparently healthy and viable preterm fetus either with active labor or with indicated delivery, severe fetal growth restriction, fetal anomaly incompatible with vaginal delivery, prior perinatal death or neonatal birth trauma, incomplete or footling breech presentation, hyperextended head, pelvic contraction or unfavorable pelvic shape, and a prior cesarean delivery. So let's now go to the labor and delivery management of a fetus in breech presentation. So there are three general methods of breech delivery through the vagina. So first, we have the spontaneous breech delivery, where the fetus is expelled entirely spontaneously without any traction or manipulation other than support of the newborn. Partial breech extraction, on the other hand, is when the fetus is delivered spontaneously as far as the umbilicus, but the remainder of the body is extracted or delivered with operator traction and assisted maneuvers with or without maternal expulsive efforts. Total breech extraction is when the entire body of the fetus is extracted by the obstetrician. First, let's talk about the spontaneous breech delivery. Similar to vertex delivery, spontaneous expulsion of a breech fetus entails sequential cardinal movements. So first, engagement and descent of the breech usually take place with the bitrochanteric diameter of the fetus in one of the oblique pelvic diameters. When the resistance of the pelvic floor is met, internal rotation of 45 degrees usually follows, bringing the anterior hip towards the pubic arch and allowing the bitrochanteric diameter to occupy the AP diameter of the pelvic inlet. So after rotation, descent continues until the perineum is distended by the advancing breech and the anterior hip appears at the vulva. Bilateral flexion of the fetal body, the posterior hip then is forced over the perineum, which retracts over the fetal buttocks, thus allowing the fetus to straighten out when the anterior hip is delivered. The legs and the feet follow the breech and may be born spontaneously or require aid. After birth of the breech, there is slight external rotation, with the back turning anteriorly as the shoulders are brought into relation with one of the oblique diameters of the pelvis. Then the shoulders descend rapidly and undergo internal rotation, with the bisacromial diameter occupying the AP plane. And immediately following the shoulders, the head, which is normally sharply flexed on the thorax, enters the pelvis in one of the oblique diameters and then rotates to bring the posterior portion of the neck under the symphysis pubis. Then the head is then born in flexion. Now we go to partial breech extraction. First, with all breech deliveries, unless the perineum is considerably lax, an episiotomy should be made and is an important adjunct to delivery. Okay, so ideally, the breech is allowed to deliver spontaneously up to the umbilicus of the fetus. Delivery of the breech draws the umbilicus and attached cord into the pelvis. Therefore, once the breech has passed beyond the vaginal introitus, the abdomen, thorax, arms, and head must be delivered promptly, either spontaneously or assisted. The posterior hip will deliver first, okay, usually from the 6 o'clock position. Then, after that, the anterior hip will deliver, followed by external rotation to a sacrum anterior position. Then the mother is encouraged to continue to push as the fetus descends until the legs are accessible. Now, the legs are sequentially delivered by splinting the femur with the operator's fingers positioned parallel to the long axis of the femur, and by exerting pressure upward and laterally to sweep each leg away from the midline outside the vagina. So as you can see here, to deliver the left leg, no, so two fingers of the obstetrician's left hand are placed beneath and parallel to the femur. So the thigh is then slightly abducted, and pressure from the fingertips in the popliteal fossa should induce knee flexion and bring the foot within reach. The foot is then grasped to gently deliver the entire leg. Now, following delivery of the legs, the fetal bony pelvis is grasped with both hands, and the fingers should rest on the anterior superior iliac crest, and the thumb should rest on the sacrum. This minimizes the chance of fetal abdominal soft tissue injury. Maternal expulsive efforts are again used in conjunction with downward traction to affect delivery. Now, to deliver the rest of the fetal body with this position, meaning the thumbs are on the sacrum and then the rest of your fingers are wrapped across the abdomen or the iliac crest of the baby, you do a gentle downward traction until the scapulas are clearly visible. So a cardinal rule here would be to apply steady, gentle downward traction until the lower halves of the scapulas are delivered, making no attempt at delivery of the shoulders and arms until one axilla becomes visible. So it makes little difference which shoulder is delivered first, and two methods are suitable for the delivery. So first, in the first method that I will show you now, with the scapulas visible, the trunk is rotated either clockwise or counterclockwise. Doesn't really matter. The aim is to bring the anterior shoulder and arm into view, okay, such as this one. Now, during delivery of the arm, the fingers and the hand are aligned parallel to the humerus, and this will act to splint and prevent humeral fracture. Okay, so once you've delivered one arm, you rotate the fetus 180 degrees in the reverse direction to bring the other shoulder and arm into position for delivery. The next method is this one. So this second method is employed if trunk rotation is unsuccessful. Now, with this maneuver, the posterior shoulder is delivered first, as you can see here. For these, the feet are grasped in one hand, and then the feet are drawn upward over the inner thigh of the mother. Now, the hand enters over the shoulder, as you can see in this picture, and fingers are aligned parallel to the long axis of the humerus, and the fetal arm is swept upward. Okay, so the posterior shoulder slides out over the perineal margin and is usually followed by the arm and the hand. Then, by depressing the body of the fetus, the anterior shoulder emerges beneath the pubic arch, and the arm and hand usually follow spontaneously. Now, after both shoulders are delivered, the back of the fetus tends to rotate spontaneously to the symphysis, and delivery of the head may then be accomplished shortly. Okay, so we have already delivered the body of the fetus. Okay, so the next part will be to deliver now the aftercoming head. Okay, the first maneuver that I will show you here is the MAURICEAU maneuver. And as you can see in this picture, the fetal body rests on the palm of the hand and the forearm of the operator. Okay, and then also the index and middle finger of the same hand are applied over the maxilla. Okay, and the reason for this is to flex the head of the fetus. Okay, you can also note here that two fingers of the other hand of the operator are hooked over the fetal neck and also grasping the shoulders. Okay, so you note also that a gentle suprapubic pressure should be simultaneously applied by your assistant. And the purpose of this is to keep the fetal head flexed. Okay, so with this position, you do a downward traction, okay, until the suboccipital region appears under the symphysis. Okay, after that, you elevate the fetal body, okay, towards the maternal abdomen, as you can see in this picture. And then the mouth, nose, brow, and eventually the occiput will emerge successively over the perineum. Okay, the next maneuver is the modified PRAGUE maneuver. And this maneuver is done when the back of the fetus fails to rotate to the symphysis, or you have a back down fetus, or you have a fetus that is facing up. Okay, so with this maneuver, two fingers of one hand are grasping the shoulders of the back down fetus from below, while the other hand will draw the feet up and over the maternal abdomen. Okay, the next method will be forceps. So we can also use specialized forceps to deliver the aftercoming head. And for this method, we use the Piper's forceps. Okay, so the Piper forceps have a downward arch, okay, in the shank to accommodate the fetal body, and it also lacks a pelvic curve. Now, this general shape, permits a direct application of the cephalic curve of the blade along the length of the maternal vagina and fetal parietal bone. Now, the blades of the forceps should not be applied to the aftercoming head until it has been brought into the pelvis by gentle traction combined with suprapubic pressure and is engaged. Suspension of the body of the fetus in a towel effectively holds the fetus up towards the maternal abdomen and helps keep the arms and cord out of the way as the forceps blades are applied. So how do we use this forceps? So generally, this is how it's done. So the blade that is to be placed on the maternal left is held in the provider's left hand. Okay, and the right hand will slide between the fetal head and the left maternal vaginal sidewall to guide the blade inward and around the parietal bone. Okay, so the opposite blade should be inserted also this way. Okay, so once the blades are in place, the blades are articulated. Okay, and the fetal body rests across the shanks, as you can see here. Okay, the head is delivered by pulling gently outward and slightly raising the handle simultaneously. And this rolls the face over the perineum while the occiput remains beneath the symphysis until after the brow delivers. And ideally, the head and body move in unison to minimize neck hyperextension. And so, unfortunately, there are instances where the aftercoming head is very hard to deliver. Okay, and that's what we call head entrapment, or what we have trapped head. Okay, this is an emergency, and this reflects either an incompletely dilated cervix or cephalopelvic disproportion. Okay, so first, especially with a small preterm fetus, an incompletely dilated cervix can constrict around the neck of the fetus and impede delivery of the aftercoming head. At this point, significant cord compression must be assumed, and time management is very, very essential. So we have to deliver the aftercoming head very quick, no, to avoid significant morbidity and mortality with the baby. Now, with gentle traction on the fetal body, the cervix at times may manually maybe manually slipped over the occiput. Now, if this is unsuccessful, then we can do this Dursens incision, no, as you can see here. So we do incision over the 1 o'clock, 6 o'clock, and 10 o'clock or 11 o'clock position. Okay, just to accommodate the exit of the fetal head. Okay, so these are incisions done over the cervix. So the trick here is to avoid the 3 o'clock and the 9 o'clock position. Other alternatives that we can do will be the following procedure. So we can give intravenous nitroglycerin, okay, or a general anesthesia with halogenated agents. And this is an option to aid in lower uterine segment relaxation. Okay, as an extreme measure, we can also do Zavanelli maneuver, where you replace the fetus higher into the vagina in the uterus, followed by a cesarean delivery. No? This Zavanelli maneuver is classically performed to relieve intractable shoulder dystocia. Okay, so we can also do this in a trapped head of a breech baby. And we can also do symphysiotomy as an extreme measure. Okay, and this is when you surgically divide the intervening symphyficial cartilage and much of its ligamentous support to widen the symphysis pubis up to 2.5 centimeters. Okay, sometimes total extraction of a complete or incomplete breech may be required, and this is what we call complete breech extraction. So how do we do this? So we have to insert our hand through the vagina and then grasp both feet of the fetus. And the ankles of the fetus are held with the middle finger lying between them, such as you see in this picture. Now, once fetal feet are grasped, no, you do gentle traction and then bring the feet into the introitus. As the legs begin to emerge, through the vulva, downward gentle traction should be continued. Now, as the legs emerge, successively higher portions of the legs are grasped. First the calves and then the thighs. Now, when the breech appears at the vaginal outlet, then we do the maneuvers that I already mentioned a few slides ago. No, gentle traction is applied until the hips are delivered, and the thumbs are placed over the sacrum, fingers over the iliac crests, and the breech extraction is then completed, as already described previously in where I described partial breech extraction. And then you do maneuvers of extraction of the aftercoming head. So in rare occasions during vaginal delivery, a frank breech will require decomposition inside the uterine cavity, and this maneuver is called the PINARD maneuver, okay, because this is attributed to Dr. PINARD. And this procedure will convert a frank breech into a footling breech. Now, this is accomplished more readily if the membranes have ruptured only recently. It becomes extremely difficult if the amniotic fluid is scant and the uterus is tightly contracted around the fetus. Now, if it's already contracted, then pharmacological relaxation by general anesthesia or intravenous magnesium sulfate, nitroglycerin, or a beta-mimetic agent may be used. Okay, so to begin, 2 fingers are carried up along one leg, such as you see in this picture. And this is the purpose of this is to externally rotate the hip by pressing on the medial side of the thigh parallel to the femur. Simultaneously, pressure in the popliteal fossa should prompt spontaneous knee flexion, which brings the corresponding foot into contact with the back of the provider's hand. Then the fetal foot may then be grasped and brought down. Okay, so during complete extraction of a frank breech, moderate traction is exerted by a finger in each groin, as you can see here, and aided by a generous episiotomy, of course. Now, once the breech is pulled through the introitus, the steps described for partial breech extraction are then completed. Now, these maneuvers are also used during cesarean delivery of a frank breech through a hysterotomy incision. Now, let's talk about version. Version is when the fetal presentation is altered by physical manipulation, either substituting one pole of a longitudinal presentation for the other or converting an oblique or transverse lie into a longitudinal presentation. And this should be done before labor. There are two kinds of version. We have the external cephalic version or the internal podalic version. Now, let's talk about external cephalic version first. So, in general, ECV is attempted before labor in a woman who has reached 37 weeks AOG. Before this time, breech presentation still has a high likelihood of correcting spontaneously. If ECV is performed too early, time may allow a reversion back to breech. Now, the contraindications to doing an ECV are as follows. If vaginal delivery is not an option, such as in cases of placenta previa or a non-reassuring fetal status, rupture of membranes, known uterine malformation, multifetal gestation, recent uterine bleeding, or a prior uterine incision. Several factors can improve the chances of a successful version attempt, and these are the following. So, if the patient is multiparous, if the patient has abundant amniotic fluid, if the presenting part is unengaged, if the fetal size is 2,500 to 3,000 grams, so not too small and not too big, if the placenta is posteriorly located, and if the patient is not obese. The risk for external cephalic version include placental abruptio, uterine rupture, and fetal-maternal hemorrhage, and this risk should be known to the patient before doing this procedure. Okay, so how do we do ECV? ECV should be carried out only in an area that has ready access to a facility that's equipped to perform emergency cesarean delivery. In other words, we only do this in a hospital setting. Okay, so because of the risk for surgical intervention, intravenous access is obtained and patients abstain from eating for 6 or more hours. So you need to tell your patient do fasting for about or for at least 6 hours. So sonographic examination is performed to confirm non-vertex presentation and also document amniotic fluid volume adequacy and exclude obvious fetal anomalies if not done previously. No? And it also identifies placental location and fetal spine orientation. So in doing the ECV, the woman should be placed in a left lateral tilt to aid uteroplacental perfusion. And also, a Trendelenburg position will help during elevation of the breech. And we also can do concomitant fetal heart rate monitoring just to monitor the baby. Okay? So, a forward roll of the fetus usually is attempted first. Okay? So, one or two providers may participate and one hand grasps the head. The fetal buttocks are then elevated from the maternal pelvis. You can see here in this picture. And it is displaced laterally. Okay, so the buttocks are then gently guided towards the fundus, as you can see in this picture, while the head is simultaneously directed towards the pelvis. Okay, it's like a forward roll. Okay, so if the forward roll is unsuccessful, then you can attempt a backward flip. Okay, ECV attempts are discontinued for excessive discomfort of the patient, persistently abnormal fetal heart rate, or after multiple failed attempts. Failure is not always absolute though, and some studies have reported a spontaneous version rate of 7% among 226 failed versions. If ECV is successful, then a non-stress test is repeated until a normal test result is obtained. If version is completed before 39 weeks AOG, then awaiting spontaneous labor and fetal maturity is preferred. Okay, so the next will be the internal podalic version. So this is used only for the delivery of a second twin, where you insert your hand inside the uterine cavity, okay, and you turn the fetus manually. Okay, so the operator seizes one or both feet and draws them through the fully dilated cervix, while using the other hand transabdominally to push the upper portion of the fetal body in the opposite direction. In other words, the internal podalic version is when you want to deliver the second twin, which is originally in a cephalic presentation, and you want to convert it to a breech presentation. Then, once you've grasped the fetal feet, then this will be followed by a the usual breech extraction, which I already discussed a few slides back. So that's it for my lecture. So in summary, we have discussed the different types of breech presentations, how to diagnose a breech presentation, the route of delivery to choose, whether we should do a vaginal or a cesarean delivery, especially for a term and a preterm breech fetus, the delivery complications, management of labor and delivery. We also talked about how to do partial breech extraction, total breech extraction, and also external cephalic and internal podalic version. So that's it for my lecture. Thank you for watching this lecture, and please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigaine. Thank you.